We'll start with the adrenal glands, the high-stakes managers of salt, sugar, and the stress response.
And from there, we'll follow the pathways through metabolic crises, the entire spectrum of thyroid dysfunction, and we'll finish up with the neuroendocrine connections and some really complex inherited cancer syndromes.
Okay, let's unpack this, beginning at the adrenal cortex, where some of the most dramatic biochemical breakdowns occur. So we're using the adrenal steroid synthesis pathway as our central analytical framework here. And that's because the first two cases are dramas centered on enzyme deficiencies, known as congenital adrenal hyperplasias, or CAH.
Right, and these are basically genetic roadblocks that even in infants can cause these critical life-altering shifts in both sex characteristics and vital signs.
What's truly astonishing about CAH, and what these cases highlight so well, is that two conditions resulting from enzyme blocks positioned incredibly close to each other in the pathway.
Yeah, they're practically neighbors biochemically.
Right. The 11-hydroxylase deficiency in case 1 and the 21-hydroxylase deficiency in case 2, they lead to clinical presentations that are essentially mirror opposites.
They really are, especially when you look at blood pressure and electrolytes. It's amazing how the specific location of that roadblock dictates sometimes life or death.
Okay, so let's start with case 1, the 11-hydroxylase deficiency. The patient is a 4-year-old presenting with ambiguous genitalia.
Yes, you see clitoral enlargement, partial labial fusion, scanty pubic hair. It's all clearly showing the effects of excess androgen action.
But the defining feature, the real clinical giveaway here, is the notable hypertension. The blood pressure is 130/89 in a 4-year-old.
That hypertension is exactly where we need to focus our analysis. It's the key.
Right.
If we look at the lab results for this child, the findings are really telling.
What do we see?
We're seeing low potassium at 3.1, high chloride at 112, high bicarbonate at 25, but the sodium is actually normal, 142.
So that combination of high blood pressure and low potassium, the hypokalemia, that usually signals some kind of mineralocorticoid excess, right?
That's the classic picture.
Yeah. But wait, this is where it gets confusing for me. If the enzyme 11-hydroxylase is deficient, shouldn't that lead to less mineralocorticoid? I mean, the enzyme is required to make the final products, cortisol and aldosterone. So why are we seeing signs of excess?
This is the central paradox of this condition, and it's absolutely critical to understand. The 11-hydroxylase enzyme is responsible for two key conversions.
Okay.
It's supposed to turn 11-deoxycortisol into cortisol, and it's also supposed to turn 11-deoxycorticosterone, or DOC, into corticosterone.
Right, the final steps in the glucocorticoid and mineralocorticoid pathways.
Exactly. So when this enzyme fails, we get two outcomes happening at the same time. First, there's a lack of cortisol.
Okay, and no cortisol means no negative feedback to the pituitary.
Precisely. So the pituitary starts screaming for more cortisol by pumping out ACTH. All that ACTH drives the whole pathway, but since the end is blocked, the precursors get shunted sideways down the sex hormone path.
And that explains the ambiguous genitalia, the masculinization.
That's part one. But it doesn't explain the hypertension. The hypertension is caused by the second outcome, the massive accumulation of the immediate precursor, 11-deoxycorticosterone, or DOC.
The one that was supposed to get converted.
Yes, it's just piling up behind the roadblock. Now, DOC is supposed to be a weak mineralocorticoid, but when it accumulates in such huge quantities, it starts to function pretty strongly.
So it's a numbers game.
It is. It starts stimulating the kidney's mineralocorticoid receptors in a big way. And this results in significant sodium and fluid retention, volume expansion, and subsequently the hypertension we see.
And that volume expansion also explains the potassium.
It does. It causes the kidney to dump potassium into the urine, leading to the observed hypokalemia.
So we have a biochemical deficit that's causing a hypertension crisis because a precursor steps in and essentially takes over the job. That is so fundamentally counterintuitive. It's a brilliant diagnostic nugget.
It absolutely is. And that accumulation of DOC is what profoundly differentiates this condition from the next case, the 21 deficiency.
Okay, so let's go there. Case 2, 21-hydroxylase deficiency. This one is much more common, right? The classic salt waster.
Much more common, yes. And here we also have a neonate with ambiguous genitalia, a masculinized clitoris, but the clinical presentation is a complete 180 from the first case.
So.
We see dangerously profound hypotension. We're talking circulatory collapse if it's not treated immediately.
So why the dramatic difference? The block is just one step earlier in the pathway?
But that one step makes all the difference. The 21-hydroxylase enzyme is necessary to create the precursors for both cortisol and aldosterone. When it's defective, the infant has an absolute lack of all active mineralocorticoids, including aldosterone and glucocorticoids, like cortisol.
So without aldosterone, the body just can't retain salt and water.
Exactly. The result is massive salt wasting from the kidneys, which leads to volume depletion, and that causes severe hypotension.
So the lab findings are the classic inverse of case 1.
The perfect inverse. You'll see hyponatremia, low sodium, and hyperkalemia, high potassium. The body is so volume depleted that it activates the renin-angiotensin system in a desperate attempt to compensate, which leads to very, very elevated serum renin levels.
And the masculinization.
Same mechanism as before. The lack of cortisol removes the negative feedback, so ACTH goes through the roof, and all the resources get shunted down the androgen path.
So that distinction, hypertension and hypokalemia in 11 deficiency versus hypotension, hyponatremia, and hyperkalemia in 21 deficiency, that is the most critical takeaway for these CAH cases.
It's everything. It's how you differentiate them at the bedside.
And the treatment for both is replacing the missing corticosteroid, specifically glucocorticoids. But the source really stressed avoiding iatrogenic Cushing syndrome. What does that mean in practice?
It means you're walking a very fine line. When we replace the missing cortisol with drugs like dexamethasone or hydrocortisone, the main goal is to suppress that out-of-control ACTH drive.
Right, to stop the androgen production.
Exactly. But if you give too much replacement, you risk causing Cushingoid adverse effects. And in a growing child, that includes critical long-term issues like bone demineralization and growth retardation. So you're always aiming for the lowest effective dose.
Before we move on, let's just briefly clarify the terminology used in these cases. We're talking about pseudohermaphroditism here, right?
Correct. The gonads, in this case the ovaries, are female, but the external genitalia are masculinized because of that androgen excess. It's fundamentally different from true hermaphroditism, which is the extremely rare occurrence of having both male and female gonadal tissue.
And these are both autosomal recessive inheritance patterns.
Yes. For case 1, the 11-hydroxylase deficiency, we're looking at a mutation in the CYP11B1 gene. It's just incredible that one small point mutation can result in such systemic chaos.
Here's where it gets really interesting, because now we shift from a single enzyme failure to a complete failure of the entire adrenal cortex, case 3, primary adrenal failure or Addison's disease.
This is a textbook chronic presentation. You have a 40-year-old woman who starts with these vague, non-specific symptoms: weakness, fatigue, feeling lightheaded when she stands up.
Things that could be anything.
Exactly. And then she crashes into an adrenal crisis with acute, severe symptoms like intractable headaches, nausea, and vomiting.
And on the physical exam, we confirm that orthostatic hypotension, a major volume problem. We see the drop from 125/75 seated to 105/60 standing.
Yes, a clear drop. But the most unmistakable physical sign, the one that tells you this failure is primary, is the diffuse patches of hyperpigmentation across her skin.
Right, the bronzing of the skin. And the labs confirm what the skin is telling us.
They do. Low sodium at 126, high potassium at 5.2, low bicarbonate at 19, and critically, a very low cortisol of 4.3. This is classic Addison disease where the adrenal gland itself is being destroyed.
Now, the most common cause is autoimmune or idiopathic, but the source rightly lists other critical dramatic causes.
Absolutely. Things like infection tuberculosis or HIV used to be more common causes, or catastrophic vascular issues like disseminated intravascular coagulation, which can lead to Waterhouse-Friderichsen syndrome.
Let's drill down on the hyperpigmentation. It's the single most important diagnostic teaching point here, connecting the pathophysiology directly to the symptom.
It really is. The low cortisol means the pituitary is trying desperately to fix the problem by ramping up ACTH secretion.
And ACTH and melanocyte-stimulating hormone, or MSH, share a common precursor molecule.
That's the key. The molecule is called POMC. When an ACTH is massively overproduced from POMC, you get a spillover production of MSH. That MSH stimulates the melanocytes in the skin, resulting in those characteristic bronze skin patches.
So if the problem were secondary or tertiary, a failure of the pituitary or hypothalamus, respectively, ACTH levels would actually be low.
Correct. And because there's no high ACTH, there's no MSH stimulation, and therefore you wouldn't see the hyperpigmentation. That single observation on the skin saves you a ton of diagnostic wandering.
It connects the dots perfectly. It narrows the possible diagnoses immediately.
It does. Now, having seen the failure states, let's move to the opposite problem: hormonal excess, starting with mineralocorticoids in case 4. This is Conn syndrome, or primary hyperaldosteronism.
Okay, case 4 involves a 35-year-old woman with weakness, tingling, and excessive urination at night nocturia and polyuria. And she has severe hypertension, 160 over 100.
And the critical lab results are almost zero serum renin activity and dangerously low potassium, down at 2.8.
So this is primary hyperaldosteronism. The term primary means the adrenal gland is acting autonomously, right?
Exactly. It's typically due to a solitary adrenal adenoma, a benign tumor which accounts for 30 to 60% of cases, or sometimes bilateral adrenal hyperplasia. It's just overproducing aldosterone regardless of what the body needs.
Okay, so let's detail the renin-angiotensin-aldosterone system, or RAAS, to understand the failure here. Why is the renin so low? That seems backwards.
Well, RAAS is the body's volume sensing and regulation system. Normally, renin from the kidney's juxtaglomerular cells kicks off the cascade. That leads to angiotensin II, which is the primary stimulator of aldosterone synthesis in the adrenal cortex.
And aldosterone's job is to promote sodium and water retention and potassium excretion.
Right. But in Conn syndrome, the adrenal gland is ignoring all that regulatory input. It's just producing aldosterone constantly on its own schedule.
So the body senses this massive fluid retention, and even with a high blood pressure, it thinks it has way too much volume.
Precisely. That excess volume acts as a massive negative feedback signal, and it just slams the brakes on the RAAS. The juxtaglomerular cells stop producing renin entirely.
And that's why the renin activity is barely detectable.
That's why. And the resulting persistent aldosterone excess drives the hypertension and, crucially, drives all that potassium out through the urine, leading to the profound hypokalemia.
And that resulting hypokalemia at 2.8 is dangerous. What does that mean for the patient's heart?
Well, hypokalemia severely alters the resting membrane potential of cardiac muscle cells. This instability manifests on an ECG as prominent U waves, T wave flattening, and ST segment depression.
All of which predispose the patient to what?
To potentially fatal ventricular arrhythmias. It's a very unstable electrical situation for the heart.
Diagnosis here involves navigating the landscape of hypertension. The source had a helpful table showing that most secondary causes of hypertension, like renal artery stenosis, actually show increased renin levels because the RAAS is activated appropriately.
Right, the kidney thinks it's not getting enough blood flow, so it screams for more volume. But Conn syndrome is the big exception. It's secondary hypertension with suppressed renin because of that primary autonomous overproduction.
And the treatment depends on the source.
It does. If it's a solitary adenoma, surgical resection and adrenalectomy is curative. If it's bilateral hyperplasia, you can't just take out both adrenals, so you go to medical management with a drug called spironolactone.
And listeners should note the side effects of spironolactone.
Yes, it's an aldosterone antagonist, but it also weakly blocks androgen receptors. This leads to some significant anti-androgenic side effects like gynecomastia in men, menstrual irregularities, and impotence. It's effective, but not without its issues.
All right, moving to our final adrenal case, case 5. Cushing syndrome, the ultimate excess glucocorticoid state.
This is a 36-year-old woman with the textbook constellation of symptoms that just screams cortisol excess. She has rapid weight gains, secondary amenorrhea, emotional lability, and hirsutism, which is excessive facial hair.
And the physical exam just confirms it. Truncal obesity, thin skin with these purple abdominal striae, and hypertension at 148 over 90.
The etiology here can be a real diagnostic maze. It could be iatrogenic from a patient taking steroids for another condition.
That's the most common cause, right?
By far. But it could also be a pituitary adenoma, which we call Cushing disease, or a primary adrenal tumor, or hyperplasia, or, and this is the chilling one, an ectopic ACTH-producing tumor, which is often a small cell lung cancer.
So the diagnosis is a beautiful example of biochemical stratification. How do you start?
First, you have to confirm hypercortisolism. You do that with screening tests, like a 24-hour urine-free cortisol test or an overnight low-dose dexamethasone suppression test. If the cortisol fails to suppress, you've confirmed the pathology.
Once it's confirmed, the next step is finding the source. And you do that using ACTH levels.
Exactly. If the ACTH is high, you know the source is outside the adrenal gland. It's either the pituitary or it's ectopic. If the ACTH is low, the source is primary adrenal. The adrenal gland is overproducing cortisol on its own, and that's suppressing the pituitary.
But how do you distinguish a pituitary adenoma from an ectopic source? They both produce high ACTH.
That's where the high-dose dexamethasone suppression test comes in. It's a clever test.
Mhm.
Pituitary adenomas, which cause Cushing disease, are usually poorly regulated, but they often retain some degree of feedback sensitivity.
So they'll respond a little bit to the high-dose steroid.
Yes, a high dose of dexamethasone will still cause a partial suppression of cortisol. Ectopic ACTH tumors, however, are typically malignant, totally autonomous, and the cortisol will not suppress at all, even with massive doses of dexamethasone.
The treatment is primarily surgical for tumors, but there are medical options.
Yes, medical management often targets the steroid synthesis pathway itself. Ketoconazole, for instance, is used because it inhibits cortisol production. Metirapone and L-glutathione also work by inhibiting steroid synthesis.
And we have to remember the normal diurnal cycle of cortisol.
We do. Cortisol normally peaks around 8 a.m. and drops to its lowest point at midnight. Many diagnostic tests rely on observing the failure of this natural rhythm. Failure of the midnight cortisol to drop is a very strong indicator of hypercortisolism.
That was a tremendous unpacking of the adrenal regulation. And having seen how cortisol ramps up blood sugar, let's now turn our attention to the system designed to manage that fuel, the pancreas, and the consequences of absolute or relative insulin failure. We start with the acute catastrophe in case 6, type 1 diabetes and crisis management.
This is such a classic pediatric presentation, a 7-year-old boy experiencing lethargy, polydipsia, drinking all the time, and polyphagia, eating all the time over several months.
And the lab work is immediate and striking. Glucose at 350.
This is autoimmune destruction of the pancreatic islet cells, leading to an absolute insulin deficiency. This is type 1 diabetes mellitus.
This forces the critical comparison between type 1 and type 2. Type 1 is that absolute deficiency, usually diagnosed in childhood or young adulthood.
Right, whereas type 2 is characterized by insulin resistance first, where the cells just ignore this signal, followed by a relative insufficiency. That's generally seen in older, often obese patients.
But both share the same terrible long-term fate. The microvascular complications of retinopathy, nephropathy, and neuropathy.
They do, but the immediate life-threatening danger in type 1 is diabetic ketoacidosis, or DKA.
Walk us through the mechanism of DKA. What is happening biochemically when the patient doesn't have enough insulin?
It's a starvation state in the midst of plenty. Without insulin, the cells cannot use glucose no matter how much is circulating in the blood. So the body switches to survival mode, thinking it's starving.
And it starts breaking down fat for fuel.
It dramatically increases lipolysis, the breakdown of fatty acids. The liver processes these fatty acids into acidic ketone bodies like beta-hydroxybutyrate and acetoacetate. The rapid accumulation of these acids overwhelms the body's buffers, and that leads to a severe metabolic acidosis.
The symptoms are profoundly distressing. Kosmal hyperemia.
Those deep, frantic respirations, yes. The lungs are trying to blow off CO2 to raise the pH. You also see severe abdominal pain and that classic sweet, fruity odor on the breath, which is caused by acetone.
Treatment is a race against time and electrolyte collapse.
It is. It demands rapid, aggressive fluid resuscitation with normal saline to combat profound dehydration. And an IV insulin infusion is the immediate priority to halt the ketone production. However, the management of potassium is the hidden danger here.
Tell us more about that potassium shift. The source notes DKA is associated with total body potassium depletion, even if the serum levels look normal or even high. Why is that?
This is a critical point that trainees often miss. The patient has been polyuric, losing huge amounts of potassium through osmotic diuresis, so they have a true overall deficit. However, the existing state of metabolic acidosis and the high circulating blood tonicity both work to push potassium out of the cells and into the blood.
So the measured serum potassium can look deceptively high or normal, but it's masking a severe total body depletion.
Exactly, and that's the trap.
So when you start the insulin,
Insulin acts as a strong driver, pushing potassium rapidly back into the cells. If you don't simultaneously replace that potassium aggressively, the patient's serum potassium levels can plummet within minutes, causing life-threatening hypokalemia and fatal arrhythmias.
what about bicarbonate? It seems intuitive to give bicarb for acidosis.
It does, but it's almost never recommended unless the pH is extremely low, like below 6.9. Rapid bicarbonate infusion can paradoxically worsen the acidosis in the brain, and it interferes with oxygen offloading from hemoglobin. So you treat the underlying cause, the lack of insulin, and the acidosis corrects itself.
That nuance in electrolyte management is a fantastic takeaway for the gravity of DKA. Now let's move past the acute type 1 crisis to the chronic, slow burn of metabolic disorder that culminates in type 2, covered in cases 11 and 15. We'll start with case 11, metabolic syndrome.
We have a 14-year-old boy with severe obesity, a BMI of 36. He has hypertension, 140/95, and a diet consisting primarily of pizza, chips, and soda. And he has the hallmark skin finding, acanthosis nigricans.
This is a classic presentation of metabolic syndrome, or insulin resistance syndrome. And the diagnostic criteria are strict, right? You need 3 of 5 features.
Yes, the NCEP-ATP3 criteria. You need 3 of the 5.
Yeah.
Abdominal obesity, elevated fasting glucose, high triglycerides, low HDL cholesterol, and elevated blood pressure.
Let's talk about the acanthosis nigricans, those velvety darkened patches, usually in the neck, armpits, or groin. It's a direct physical marker of the pathology.
It is. It's caused by the chronic hyperinsulinemia itself. The high circulating insulin levels activate insulin-like growth factor receptors in the skin, which results in that hyperpigmentation and thickening. It's also often associated with polycystic ovarian syndrome and sometimes visceral malignancies.
So if the skin is a sign of hyperinsulinemia, what exactly is insulin resistance?
Insulin resistance is the core pathology of type 2 diabetes. It's the state where insulin, whether produced by your own body or administered as a shot, generate a suboptimal biological effect.
So the cells are just ignoring the signal.
They are. The patient has elevated blood glucose, but the pancreas is churning out insulin in overdrive to compensate. So you have high or normal insulin levels, but they're just not working properly.
And the source points directly to visceral fat is the key culprit.
Visceral fat, that deep abdominal fat, is highly metabolically active. It releases increased free fatty acids, which directly interfere with insulin signaling. It also releases pro-inflammatory cytokines and adipokines that further modify insulin's effectiveness. It's a multi-pronged assault on the signaling pathway.
Treatment prioritizes aggressive lifestyle changes, but metformin is the go-to agent to mitigate the insulin resistance. You mentioned the source's strong cautionary note about atypical antipsychotics.
Yes, we see this frequently in clinical practice. Drugs like clozapine and olanzapine are notorious for causing weight gain and inducing or worsening metabolic syndrome. They significantly increase the risk of cardiovascular events, especially in patients who already have underlying IR or hyperglycemia. We have to be really vigilant about this iatrogenic risk.
Now we move to case 15, the full manifestation, type 2 diabetes mellitus. A 30-year-old woman with morbid obesity, a BMI of 48, hypertension, and recurrent UTIs. Her urine shows protein and glycosuria.
The official criteria for diagnosis are crucial to nail down. A random glucose over 200 with symptoms, a fasting plasma glucose over 126 on 2 separate occasions, or a plasma glucose over 200 2 hours after an oral glucose tolerance test.
Before we discuss the pharmacologic management, let's quickly review insulin synthesis because it informs one of our key diagnostic tools, C-peptide.
Right, so insulin is synthesized in the pancreatic beta cells as a large molecule called pre-proinsulin. This is processed into proinsulin, which is then cleaved. That cleavage yields the final active insulin molecule, the A and B chains linked by disulfide bonds, and a fragment called C-peptide.
So C-peptide is cleaved off when endogenous insulin is produced.
Exactly. So its level is used clinically to determine how much insulin the patient's own pancreas is still producing. It's a great marker of beta cell function.
And the effects of insulin are massive. It stimulates glucose uptake into muscle and fat cells, tells the liver to store glucose as glycogen, and promotes triglyceride and amino acid storage.
The entire treatment strategy for type 2 DM revolves around either stimulating the pancreas to produce more insulin, making the existing insulin work better, those are the sensitizers, or slowing down glucose absorption from the gut. The goal is lifelong HbA1c control to minimize those devastating microvascular and neurologic complications.
Let's dedicate some time to the specific pharmacologic agents from the source, breaking down the mechanisms and, crucially, the risks. Starting with the first-line therapy, metformin, the big one-eyed.
Metformin is the powerhouse. Its exact cellular mechanism is still being elucidated, but its clinical effects are crystal clear. It dramatically decreases hepatic gluconeogenesis, the liver's production of sugar, and it increases glucose uptake in peripheral tissues.
And it works orally, isn't dependent on islet function, and generally doesn't cause hypoglycemia on its own.
All true. It's a remarkable drug.
So what's the big risk? Why is it contraindicated in renal failure?
The most grave adverse effect is lactic acidosis. Metformin is excreted by the kidneys. If the kidneys are failing, the drug builds up to toxic levels. This disrupts mitochondrial function and shifts the cellular metabolism toward anaerobic respiration, which creates lactic acid.
And if the kidneys can't clear the metformin or the lactic acid?
The patient develops a profound, often fatal, lactic acidosis. This makes its use in any patient with poor kidney function an absolute no-go.
Let's move to the agents that directly stimulate insulin release. The sulfonylureas, like glyburide and glipizide.
These are known as secretagogues. They work by binding to and closing the ATP-sensitive potassium channel in the beta cells. This depolarization triggers a cascade that forces the release of endogenous insulin.
And the clinical relevance is obvious. They are entirely useless in type 1 diabetes.
Completely useless because there are no functional beta cells left to stimulate. The primary toxicity is hypoglycemia, especially with the second-generation agents. And the first-generation drugs carry a risk of disulfiram-like reactions if you consume alcohol.
Next up, the sensitizers, the TZDs, like pioglitazone and rosiglitazone.
These increase insulin sensitivity by working inside the cell. They bind to the PPAR gamma nuclear receptor, which is critical for adipocyte differentiation and lipid metabolism. By activating this receptor, they improve glucose uptake in fat and muscle tissue.
But they have some serious liabilities.
They do. They cause weight gain and fluid retention, leading to edema. And there's a potential for hepatotoxicity. Rosiglitazone in particular has been associated with cardiovascular risk, which has really tempered its widespread use over the years.
We have two more classes. The alpha-glucosidase inhibitors, like acarbose, and the mimetics.
Alpha-glucosidase inhibitors are unique because they don't affect systemic hormones. They work right in the gut-brush border, inhibiting the enzymes that break down complex carbohydrates into absorbable simple sugars.
So they delay sugar absorption and blunt the post-meal glucose spike.
Exactly. They are effective but notoriously cause significant GI disturbances like flatulence and bloating because of the undigested carbohydrates moving down to the colon.
And finally, the mimetics.
Mimetics, like the GLP-1 agonists, such as exenatide, and the amylin analogs, like pramlintide, work by modulating gut hormones. They generally enhance insulin secretion, suppress inappropriate glucagon release, and increase satiety while slowing gastric emptying.
And they often cause weight loss, which is a huge benefit.
A huge benefit. They are highly effective. But common toxicities include nausea and diarrhea, and importantly for the GLP-1 analogs, there is a risk of pancreatitis that we always have to keep in mind.
That deep dive into type 2 pharmacology was critical. Now we shift gears dramatically to the thyroid gland, the body's primary metabolic governor. We'll start with the conditions of excess. Hyperthyroidism in Graves' disease, which is case 8, and Plummer disease in case 20.
Case 8 is the classic picture of a racing engine. We have a 30-year-old woman presenting with a racing heart, excessive sweating, rapid weight loss despite eating, and profound nervousness and restlessness.
And the physical exam confirms it all. Tachycardia, a fine body tremor, and the defining, unique feature of Graves, bilateral exophthalmos or bulging eyes.
Graves' is fundamentally an autoimmune disorder, and it's significantly more common in women. But the mechanism of this autoimmune attack is what's really fascinating.
What's going on there?
The immune system produces these things called thyroid-stimulating immunoglobulins. They're antibodies that are structurally very similar to TSH.
So they don't just mimic TSH.
They do more than that. They bind to the TSH receptor on the thyroid gland and relentlessly activate it, 2047. And since this activation is not subject to pituitary feedback, the gland just produces massive, unregulated amounts of T4 and T3.
And the importance of the ophthalmopathy and the pretibial myxedema, that waxy skin change, is that they are unique to Graves.
Absolutely. The other causes of hyperthyroidism, like an overdose of thyroid medication, a painful thyroiditis, or the autonomous nodules we'll discuss next, they do not cause that eye or skin infiltration. That infiltration is caused by the autoimmune attack itself, often mediated by T lymphocytes attacking tissues that share antigens with the thyroid.
And the ultimate emergency here is thyroid storm.
This is a life-threatening surge of thyroid hormone into the blood, often triggered by stress, infection, or surgery. The patient presents with extreme hyperthermia, a heart rate often exceeding 140 beats per minute, delirium, and eventually coma.
Treatment has to be immediate and multifaceted.
It does. Methimazole to block hormone synthesis, iodine to block hormone release, and agents like propranolol that reduce the peripheral conversion of T4 to the more active T3. It's an all-hands-on-deck situation.
Let's contrast this autoimmune hyperthyroidism with case 20, Plummer disease or toxic multinodular goiter.
This case involves an older patient, a 77-year-old man with a long-standing large mass in his neck. He's presenting with systemic symptoms of hyperthyroidism, fatigue, weight loss, and importantly for an older patient, new onset atrial fibrillation.
And the labs show what you'd expect. Elevated free T4 and a barely detectable TSH. The pituitary is completely suppressed.
The diagnosis is often driven by the physical exam. You feel a large, firm, multinodular goiter in contrast to the smooth, diffuse enlargement you see in Graves's.
And Plummer disease is the second most common cause of hyperthyroidism.
It is, and in areas of chronic iodine deficiency, it actually becomes the primary cause. The large mass itself can cause mechanical compression, leading to dysphagia, difficulty swallowing, hoarseness, or dyspnea.
And there's also the Pemberton sign?
Yes, that's where you see engorgement of the neck and facial veins when the patient raises their arms. It signals superior vena cava syndrome caused by the huge goiter pressing on the vein.
So how does imaging definitively differentiate Graves from Plummer?
The radioactive iodine uptake scan is the key. In Plummer disease, you see multiple hot nodules, small autonomous areas of the gland that have mutated and are now producing hormones independently of TSH. The rest of the gland is suppressed and looks cold.
And in Graves?
In Graves, you see diffuse, uniform uptake across the entire gland. The whole thing is overactive. In contrast, thyroid cancer nodules and thyroiditis typically show low uptake, so we call them cold nodules.
Okay, now let's look at the flip side. Hypothyroidism, where the engine runs too slowly, starting with case 10. Hashimoto thyroiditis.
This is a 52-year-old woman with generalized weakness, profound cold intolerance, and insidious weight gain. The physical exam signs are classic hallmarks of a slowed metabolism.
Like what?
Generalized hair loss, or alopecia. A thick and beefy tongue. Non-pitting edema, known as myxedema, and the telltale sign, the delayed relaxation phase of her deep tendon reflexes.
And the labs confirm primary hypothyroidism. Very low free T4 and a tremendously high TSH of 31. The pituitary is just screaming, but the thyroid gland isn't responding.
Hashimoto thyroiditis is the most common cause of primary hypothyroidism. It's an autoimmune destruction of the gland, and patients are usually positive for antithyroid peroxidase antibodies. It also often clusters with other autoimmune disorders like vitiligo.
It's important for our listeners to understand the difference between primary and secondary hypothyroidism based on that TSH level.
It's the key distinction. If the TSH is high, the thyroid is the problem. That's primary. If both the TSH and the T4 are low, the problem is upstream, usually in the pituitary. That's secondary hypothyroidism.
And that might also manifest with other pituitary deficits.
Exactly. Things like sexual dysfunction due to FSHLH deficiency, or even diabetes insipidus due to ADH deficiency from the posterior pituitary.
Treatment is simple, conceptually at least. Levothyroxine, the synthetic T4 hormone.
Yes. And we need to remember that T4 is the major product from the gland, but T3 is the active hormone, which is converted in the peripheral tissues by deadenases. T4 is absolutely essential for things like brain maturation in infancy and maintaining the basal metabolic rate throughout life.
Before we get to malignancy, let's briefly touch on case 17, which is a purely structural issue, the thyroglossal duct cyst.
Right. This is a 13-year-old girl with a lump in her neck that appeared after an infection. The key diagnostic sign is that it's a round, mobile midline mass that elevates with swallowing.
And this is an embryological relic.
It is. The thyroid develops at the base of the tongue and descends down to the neck, connected by the thyroglossal duct. This duct typically obliterates by the 7th week of gestation. If remnants persist, they can form a fluid-filled cyst.
And the elevation with swallowing is key because the cyst is usually attached to the hyoid bone, which moves with those actions.
Exactly. And you have to consider the differential diagnosis, separating these midline masses from lateral ones, like branchial cleft cysts or enlarged lymph nodes.
And there's a practical note on ectopic thyroid tissue.
Very important one. Ectopic thyroid tissue is often found at the base of the tongue, a lingual thyroid. Before a surgeon removes any suspected ectopic tissue, they must confirm the patient has a functioning thyroid gland in the normal position. Otherwise, you've just induced surgical hypothyroidism that requires lifelong replacement.
That brings us to malignancy in case 18. Papillary thyroid cancer, or PTC, the most common form.
This case involves a 55-year-old pilot with a firm, worrisome nodule in the thyroid that remains fixed with swallowing. That fixation suggests local invasion, which is a red flag.
And the diagnosis is confirmed by a fine needle aspiration, an FNA, revealing the pathognomonic findings: ground glass cytoplasm, inclusion bodies, and calcifications.
PTC accounts for about 85% of all thyroid cancers. The key to diagnosis is risk stratification.
How do you do that?
First, we measure TSH and perform an ultrasound and an FNA. This is where the functional status matters immensely. Hot nodules, the ones producing hormone and suppressing TSH, are rarely malignant. Cold nodules, the non-functional ones, require aggressive biopsy.
And what are those classic histopathological hallmarks that make PTC so memorable?
They are very unique. The nucleus looks clear and empty, which is described as orphan Annie inclusion bodies. You see prominent nuclear grooves and clefts, and you see calcified symoma bodies. The risk factors are also very clear. Female sex, age 20-60, a single nodule, and a history of prior radiation exposure, particularly in childhood for conditions like acne.
And the treatment is radical.
It is. Total thyroidectomy, often with regional lymph node dissection, followed by postoperative radioactive iodine ablation to destroy any remaining microscopic disease.
That surgical treatment brings us directly to case 19, the delicate anatomy of thyroidectomy, which highlights the acute surgical risks.
A total thyroidectomy, especially after radiation therapy, which can scar the anatomy, requires meticulous precision to avoid two critical structures, the parathyroid glands and the laryngeal nerves.
Right, most people have 4 parathyroid glands situated right behind the thyroid.
They do. And if you accidentally remove them all, the patient will develop acute symptomatic hypocalcemia right after the surgery. Surgeons often will auto-implant any inadvertently removed parathyroid tissue into the patient's arm muscle to try and maintain function.
And the other, perhaps more common complication is nerve injury. Where is the highest risk?
The recurrent laryngeal nerve, or RLN, is most at risk. It runs in the tracheoesophageal groove and supplies most of the muscles that control the vocal cords.
So injury leads to a hoarse voice.
A permanent hoarse voice with a unilateral injury or catastrophically airway obstruction if you injure both. You also have to be careful ligating the superior thyroid artery, as the external laryngeal nerve runs nearby and supplies the cricothyroid muscle.
And post-total thyroidectomy, lifelong levothyroxine replacement is mandatory.
Absolutely. And the TSH levels are often kept suppressed, very low, to prevent any stimulation of potential recurrence of the cancer.
We've covered the organs that dictate metabolic rate and salt-sugar balance. Now we dive into the 4 tiny glands that govern bone density and nerve firing. The parathyroids. Case 9 is hyperparathyroidism and hypercalcemia.
We're presented with a 62-year-old woman with these chronic, vague complaints: diffuse bone pain, constipation, vague abdominal discomfort, nausea, and vomiting. And she simply attributed all this to getting old.
But the labs revealed a silent pathology: strikingly high calcium at 12.3, a reciprocally low phosphate at 2.0, and a PTH level of 100. Now, that level might be on the upper edge of normal, but it's highly inappropriate given the severe hypercalcemia.
It's completely inappropriate. When calcium's high, PTH should be suppressed to nearly zero. The fact that PTH is still being secreted proves autonomous production.
So this is primary hyperparathyroidism.
Yes, usually caused by a PTH-producing adenoma in about 80% of cases. It's the most common cause of hypercalcemia in outpatients. The broader differential for hypercalcemia is captured by the mnemonic MIHAP.
What does that stand for?
Malignancy, which is the most common cause in hospitalized patients, intoxication with vitamin D sarcoidosis, hyperparathyroidism, alkali syndrome, and Paget disease of bone.
Okay, so let's detail the precise role of PTH. How does it manage calcium?
PTH is the primary calcium regulator. It acts on 3 main sites. First, the bone. It stimulates osteoclasts to resorb calcium directly from the skeleton.
So it's breaking down bone to raise blood calcium.
Correct. Second, the kidney. It dramatically increases calcium reabsorption in the distal tubules while simultaneously increasing phosphate excretion. And third, it stimulates the kidney to convert vitamin D into its active form, 1025-dihydroxyvitamin D.
And then vitamin D assists by promoting calcium reabsorption from the bone and, crucially, from the small intestine. Calcitonin is the antagonistic hormone, but its role is often described as minimal in humans.
That's right. And the clinical symptoms we saw, the bone pain, constipation, mental status changes, are summarized beautifully by the classic rhyme: painful bones, renal stones, abdominal groans, and psychic moans.
The source also stratified hyperparathyroidism into 3 types.
Yes. Primary is the autonomous adenoma we just discussed. Secondary is a physiological, appropriate response to a chronic low calcium state, most often seen in chronic renal failure.
Why renal failure?
The failing kidneys cannot activate vitamin D, which leads to hypocalcemia. That low calcium causes the parathyroid glands to hypertrophy and secrete massive amounts of PTH to compensate.
And tertiary.
Tertiary occurs when that long-standing secondary hyperparathyroidism becomes so severe that the gland transitions into an autonomous adenoma itself, and it starts ignoring regulatory feedback once again.
Treatment for acute severe hypercalcemia requires massive fluid resuscitation and loop diuretics to force calcium excretion. But the long-term curative treatment for primary disease is parathyroidectomy.
Yes, which boasts a very high cure rate, over 95%.
Now for the opposite extreme, case 14, hypoparathyroidism and neurological signs. This is a 10-year-old girl with new onset seizures, numbness and tingling, and muscle cramps. On exam, she has a short, stocky stature and shortened 4th and 5th digits.
And the labs show profound hypocalcemia at 7 and high phosphate at 6, but her PTH level is reported as high at 100.
This is the second diagnostic twist of the day. If calcium is low and the PTH is not low, the target organ must be unresponsive.
Exactly. This is pseudohypoparathyroidism type 1A. The kidney receptors are resistant to the high PTH, usually due to a GUS protein mutation. The physical findings, the short stature, round face, shortened digits, are collectively known as Albright hereditary osteodystrophy.
In contrast, if the PTH had been truly low, that would typically be iatrogenic.
Yes, meaning accidental removal or damage to the parathyroid glands during a prior thyroid surgery. That's the most common cause of true hypoparathyroidism.
Regardless of the cause, low calcium produces these dramatic neurological and neuromuscular symptoms. Why?
Because calcium is essential for stabilizing nerve membranes. When calcium is low, the nerves become hyperexcitable. That excitability manifests as muscle cramps and 2 classic signs that you must test for on exam.
The Shostak's sign.
Right. Tapping the facial nerve just anterior to the ear causes an ipsilateral facial muscle twitch. And then there's the Trousseau sign.
How do you elicit that?
You inflate a blood pressure cuff above the systolic pressure for 3 minutes, and it provokes painful carpal or hand contractions.
And the cardiac effects are also critical. Hypocalcemia prolongs the QT interval on the ECG.
It does, and this increases the risk for a dangerous arrhythmia called torsades in points. This is the exact opposite of hypercalcemia, which actually shortens the QT interval.
We've saved the most interconnected systems for last, bringing the hypothalamus, pituitary, and adrenal medulla into focus. We start with the pituitary, the master gland, in case 7, gigantism and acromegaly.
This is a 12-year-old boy whose mother noticed he was too tall. The physical features are striking: large hands and feet, frontal bossing of the cranium, a prominent jaw, and coarse facial features.
And the diagnosis depends entirely on timing, relative to skeletal maturity. If this excess growth hormone, or GH, occurs before the epiphyseal plates fuse, it results in gigantism.
Right. If it occurs after fusion, you get acromegaly. The cause is almost universally a GH-producing pituitary adenoma.
So GH is produced by somatotropes in the anterior pituitary and is released in a pulsatile fashion. Its regulation is complex.
It is. It's stimulated by hypothalamic GH-releasing hormone, or GHRH, and it's inhibited by somatostatin and peripheral IGF-1 via negative feedback. Those pulses increase significantly during puberty to fuel the growth spurt.
Diagnosis is tricky because GH fluctuates so much throughout the day.
That's why we don't rely on a random GH reading. We screen using serum IGF-1 levels. IGF-1 release, which is stimulated by GH, is much more stable throughout the day.
And the gold standard confirmatory test is the oral glucose suppression test.
Right. In normal patients, a large glucose load should suppress GH secretion.
But in patients with an autonomous GH-producing tumor, the GH levels fail to suppress.
Correct. They either stay the same or suppress only partially, proving that the tumor is ignoring the normal regulatory signal. Once that's confirmed, an MRI of the pituitary locates the adenoma source.
Now we look at a profound failure of the pituitary in case 16, Sheehan syndrome, or postpartum pituitary necrosis.
This is a dramatic life-or-death case. A 32-year-old woman, 4 days postpartum, following a delivery complicated by massive hemorrhage. The early red flag is the failure to lactate.
Meaning a prolactin deficiency.
Exactly. But she also presents with intense lethargy, weakness, and critically vital sign instability with severe orthostatic hypotension. Her systolic pressure drops from 90 supine to 80 standing.
And the cause is that the massive hemorrhage caused ischemia and necrosis of the pituitary gland, specifically the highly vulnerable anterior pituitary.
This is a state of panhypopituitarism. Remember the anterior pituitary hormones ACTH, GH, TSH, FSH, LH, prolactin. The sequential loss of all of these hormones is devastating.
But the orthostatic hypotension and cardiovascular instability are the acute dangers. Why is that specific vital sign drop so dangerous, and what connection does it have to the hormones we discussed earlier in Addison's?
This is where the systems link up beautifully. That severe systolic blood pressure drop upon standing signals cardiovascular collapse. The loss of ACTH means secondary hypocortisolism.
And cortisol is essential for vascular tone.
It's absolutely essential for maintaining the integrity and tone of the peripheral vasculature. It allows blood vessels to respond appropriately to catecholamines. Without cortisol, the vascular system is floppy. It cannot compensate for gravity when the patient stands up.
So the mechanism of vascular collapse in Sheehan syndrome, the lack of cortisol due to lack of ACTH, it mimics the vascular collapse risk we saw in Addison's disease.
Exactly. The final outcome is the same severe hypercortisolism, which is a major emergency. This patient will require lifelong replacement of all deficient hormones, including thyroxine and cortisol, to prevent further crises.
Let's move to the adrenal medulla in case 13, pheochromocytoma.
This 50-year-old woman presents to the ER with a classic paroxysm of symptoms: vertigo, a severe headache, palpitations, blurred vision, and profuse sweating, or diaphoresis. And her blood pressure is catastrophically high, 200/140.
This is the signature of a pheochromocytoma, a catecholamine-secreting tumor originating from the chromaffin cells of the adrenal medulla, leading to these sporadic, massive surges of epinephrine and norepinephrine.
Diagnosis focuses on identifying the breakdown products of those catecholamines. We look for elevated plasma metanephrines and normetanephrines, or elevated 24-hour urinary catecholamines and their metabolites.
Let's detail that catabolism because it's highly specific. Catecholamines are broken down by two major enzymes, MAO and CONT.
Right. CONT converts epinephrine into metanephrine. MAO then converts that metanephrine into the common final product, 3-methoxy-4-hydroxymandelic acid, or VMA. The pathway can also go the other way, but VMA is the common end product we measure in the urine.
Physiologically, those massive surges of epinephrine and norepinephrine cause the symptoms. Alpha receptor activation causes the hypertension.
Profound vascular smooth muscle constriction, yes. And beta receptor activation causes the increased heart rate, contractility, and conduction velocity, which leads to the palpitations.
Surgical removal is curative, but the surgical planning is critical.
It is. The surgeon must secure the adrenal vascular supply before manipulating the gland, particularly the adrenal vein. If you manipulate the tumor before securing the vein, you can squeeze massive amounts of pure catecholamines directly into the systemic circulation,
Causing a fatal hypertensive crisis on the operating table.
Exactly.
We mentioned the 10% rule earlier for these tumors.
Yes. Roughly 10% are malignant, 10% are bilateral, 10% are extraadrenal, and 10% are familial, which leads us directly to our final case. Case 12, multiple endocrine neoplasia type IIA.
We have a 40-year-old woman presenting with hoarseness, palpitations, headaches, hypertension, and a lump at the base of her neck. A biopsy of the lump confirms medullary carcinoma of the thyroid, or MTC, characterized by amyloidostroma.
That MTC diagnosis is essentially diagnostic for MEN-IIA, or Sippel syndrome. The classic triad is medullary carcinoma of the thyroid, pheochromocytoma, and parathyroid hyperplasia.
And it's crucial to understand the genetic basis and the other MN types.
It is. MEN-I, or Romer syndrome, is autosomal dominant and involves the 3 Ps: pituitary adenomas, pancreatic islet cell tumors, like Zollinger-Ellison tumors, and parathyroid adenomas.
And MEN-IIA is the MTC, pheo, and parathyroid triad. MNIIB includes MTC and pheo, but replaces the parathyroid issue with a marfanoid habitus and mucosal neuromas.
The underlying genetic cause for both IIA and IIB is a mutation in the RET oncogene. So diagnosis requires confirming the MTC with elevated calcitonin, screening for the pheochromocytoma with VMA and metanephrines, and checking for hyperparathyroidism with an elevated PTH.
And since this is an autosomal dominant condition, a person with that RET mutation has a clear 50% probability of passing it to their children.
That underscores the immediate need for genetic counseling and proactive screening of family members, particularly because MTC can be an aggressive cancer and an undiagnosed pheochromocytoma can be fatal.
That was a tremendous journey, moving from a single enzyme deficiency in the adrenal pathway all the way up to these inherited multisystem cancer syndromes. We truly traverse the entire chemical command structure of the body.
If we connect this to the bigger picture, these 20 cases really illustrate the astonishing complexity of endocrine feedback loops. We saw that whether a patient develops hypertension or hypotension can hinge entirely on where an enzyme roadblock is located in the adrenal cortex.
Right, and we detailed why a specific autoimmune attack on the thyroid dictates whether a patient has diffuse or nodular uptake on a scan.
Exactly. The body relies on this precise communication, and a disruption in one system, TSH, ACTH, PTH, GH, it always manifests as dramatic, interconnected, multi-system symptoms that demand careful differential diagnosis.
We detailed the nuanced distinctions required for diagnosis, such as why 11-hydroxylase deficiency causes hypertension versus the salt-wasting crisis of 21-hydroxylase deficiency. We meticulously broke down the management of metabolic failure, focusing on the specific mechanisms and life-threatening risks of every major drug class used for type 2 diabetes.
Especially the risks associated with metformin and the delicate fluid management required for DKA.
So you now have the fundamental, detailed knowledge required to decode the body's most sensitive chemical messengers. So what does this all mean for you?
Well, we finished on the topic of MEN-EIA, where the genetic mutation, the RET oncogene, is inherited with a 50% risk. We noted that early diagnosis is absolutely critical for managing medullary thyroid cancer and pheochromocytoma before they become fatal, and this raises an important question that extends far beyond the clinical setting.
Which is?
Given the high penetrance and severity of diseases like MEN-EIA and our growing ability to detect these genetic markers with accuracy, what role should proactive, population-wide genetic screening play in managing complex, highly penetrant endocrine disease risks even before symptoms appear? Because if we wait for the hypertension, the headache, or the palpable lump to appear, we may have already lost the window for the best therapeutic intervention.